he ended up having lung cancer, but he never, ever, ever smoked a single cigarette.
Smoking is a risk factor for lung cancer, but it's not a cause for lung cancer. Also interesting that it's been found in Asia, most of our lung cancer comes from non-smokers.
So the good cells can get damaged as well at the
Yes,
same time.
good cells can get damaged. That's why patients do get side effects. These side effects can come on soon after radiation, so within weeks, and rarely they can come on even years later. So our job really is to give the highest cure rate at the lowest risk of side effects.
And immunotherapy, in short, is basically therapy that activates your own immune system to fight the cancer cells.
So activate their own immune system. Wow, that's
Yeah.
amazing.
Most people think cancer equals to chemotherapy and equals to, equals to death, right?
Yeah, if you ask, exactly, that's what I think. Yeah.
Yeah, but I think it's important to know that that is not the case anymore.
Health matters. It's something very important. Health is always important for everybody, for me also. So one of the reasons I'm doing this is to share simplified version of health hacks, right? This will help individuals when you listen to this, you'll be able to get the accurate information from the specialists themselves. That's the reason I'm doing this. One day I was going through Google. There was a bit of pain on the right hand side, so I Googled it, and then there's a different reason. Wow, why this is why the pain was there, and then finally I started reading, and I realized that, oh my God, actually it's a very serious, big thing, and I have to have that particular medicine to be cured. Then I was like, wow. But then I realized, then I did some research and found out that this article was written by some other company instigating some other behind the scene to be projected to the audience. So then I realized how many times we go and search about health, but how many search about wealth, right? But then, are these information accurate or not? Of course, thank God, going back to my story, nothing serious, it's just a pain. So then I realized that how can I help the people around me, my community, my friends, my family, saying that, okay, this is the correct information. So that's the whole intention of doing Health Matters. Of course, you matter and health matter as well. So being the first episode of Health Matter, I'm very excited, you can see that. But loving this because I am in a mode to contribute, and through this program, through this podcast, we want to help millions out there so that they can, when the time comes, they can make the correct decision. They can make the correct choice. So I'm actually very excited and privileged to say that our very first episode of Health Matters is being represented by two of the eminent oncologists, a medical oncologist and a radiation oncologist from Singapore, Parkway Cancer Center. I had the privilege of working with these two giants for last 2-3 years. It has been an amazing journey. And today they are with us. Let me introduce Dr. Tanujaa. So she's a medical oncologist, and she's subspecialized in head, neck, lung, and genitourinary cancer, and a very unique cancer called geriatric cancer. She has a clinic at Mount Elizabeth Orchard, Mount Elizabeth Novena, and Clinicals in Singapore. And we will be learning a lot about it. What is cancer, and what are the facts and myths through this podcast. And of course, I call him the man with the machine, heavy artillery. So Dr. Ivan, I had a privilege to know him for last 2 years. Yeah. So he's a radio oncologist. So he has various kind of powerful machine. He's going to share it with us to treat the cancer. They're managed in a way so that they're able to have a normal life, whereby it will help them to have a better life. Okay, so but then again, we'll let Dr. Ivan to talk about that, and he has his clinic at Mount Elizabeth Orchard, Mount Elizabeth Novena, and Glen Eagles Hospital. And guess what? The both of them are at the studio. Welcome both of you at the first episode of Health Matter. Thank you very much, Dr. Tanujaa. Thank you, Dr. Ivan, for joining.
Thanks, Shuo, for having us. It's our pleasure to be here on the first episode.
Great. I'm excited, as you can see. So, Dr. Tanujaa, what is cancer?
Okay, so we'll start off. So cancer is something that obviously all of us are afraid of, right? But we start with the definition first. So cancer is basically the uncontrolled growth of abnormal cells, and cancer can occur in any part of the body, in any organ. The problem happens when, let's say, you have this abnormal cell that continues to grow and it affects the function of the organ which it is in, and this abnormal cells can potentially also spread or metastasize to other parts of the body, and they can affect the function of other organs in the body, and that's why cancer is generally a big problem. The other big issue with cancer is because nowadays in our developed world, cancer rates are increasing, and in Singapore, from where we come from, it is said that 1 in 4 people will be afflicted with cancer. Those are really very sobering numbers.
1 in 4.
Absolutely.
My God. Okay, so can you say in the room? That means there will be one person will have a. Okay, got it. Okay, wow. Is it a high number?
Definitely. So 1 in 4, as you exactly said. So if there's 4 of us in this room now, 1 of us potentially will be afflicted by cancer, and there's a risk of 20% risk of dying from cancer.
Got it. So what's the difference between benign and malignant tumors?
Again, a great question. So a benign tumor is something that is non-cancerous. What happens is these cells, they just grow, but they do not invade the surrounding tissues, and they do not spread to other parts of the body. The problem with benign tumor, for example, if I have a benign tumor of the lung, it can, or for the brain for that matter, it just grows and grows, and it can cause local effects like compression and things like that. But a benign tumor will never spread to other parts of the body. In contrast, a malignant tumor is cancerous, and it can invade the surrounding tissues, and it can spread or metastasize to other parts of the body.
Okay, so how does genetic and environment around us impacts cancer?
So again, great question. So in terms of genetics, there are many ways genetics can affect our development of cancer. So there's something called inherited genetic mutations. So some people can inherit mutations from their parents, and these are what we call germline mutations. So you are born with that mutation. So for example, there's this mutation that you may have heard of. It's called the BRCA mutation. So if you have that mutation, if you have inherited it from your parents, you are increased risk of breast cancers, ovarian cancers, and pancreatic cancers, for example. And there are many other possible inherited genetic mutations, right? And there are also other things, what we call somatic mutations. These are mutations you don't inherit, but over time, as you grow older, as the cell ages, there may be issues with the cell repair, where your normal cell acquires mutation and potentially become turned into cancer cells, right? And with regards to environmental changes, and there are many environmental factors that affect the development of cancer. For example, exposure to carcinogens like cigarette smoke. So if you are a smoker, obviously you are increased risk of certain type of cancers like lung cancer, bladder cancer. And when we talk about environment, we also talk about lifestyle factors like food. Nowadays we have a lot of processed food,
yes,
and it has been said to be an increased risk of developing certain sort of cancers like colorectal cancers as well.
But then again, I heard that I have a friend. He ended up having lung cancer, but he never ever smoked a single cigarette.
Okay. So exactly. So smoking is a risk factor for lung cancer, but it's not a cause for lung cancer. Risk factor means that smoking increases your chance of getting cancer, but it's not a definite thing that if I smoke, I'm definitely going to get cancer. And what is also interesting, that has been found in Asia, most of our lung cancer comes from non-smokers.
Okay.
So and it's interesting to know that the type of lung cancer that occurs in smokers is different for the type of lung cancer that occurs in non-smokers, right? And because non-smoking related lung cancer is a big thing in Asia, and in Singapore, it is said that about 60% of our lung cancer occurs in non-smokers.
Okay.
Right. So that brings us back to the point that just because you don't smoke, if you have any symptoms related to the lungs, like a persistent cough, or if you have difficulty breathing, please don't think that, just because I don't smoke, I'm not going to be at risk of getting lung cancer. You will still be at risk. You can still be at risk.
Right.
Yeah?
Okay, so it's always a possibility of...
Absolutely.
So it's about lifestyle mainly, is it?
That lifestyle is a component,
Right.
of developing lung cancer, but it is not. But you could, I've seen patients who've come to see me. They've done everything right. They you don't smoke, you don't drink, you exercise, and
Right.
and then they still develop cancers.
Right.
So of course, what we can do things to reduce our risk of cancers, but if you ask me, is there a surefire way to make sure that that's 100% I'm not going to get cancer? The short answer is actually no.
Got it. Great. So, Dr. Ivan, I believe radiotherapy has evolved, right?
Yes.
So, before we get into that, what is radiotherapy?
So our field is commonly known as radiation oncology. So that basically summarizes what we do. We use radiation to treat cancer. There are various forms of radiation we use. Typically, we use X-rays. That's the most common. Now and then, we use electrons, and in Singapore and in some countries, there's also the possibility to use protons to treat cancer.
Okay. Where you say it is radio oncology, correct?
Yes.
Okay, got it. So just wanted to double confirm on that, because what happens is that we hear so much about radiotherapy. It can improve this, improve that. So when it comes to lung cancer or
Yes.
urological cancer, what do you think it can contribute?
Well, that's a great question. So for lung cancer, we can offer radiation instead of surgery in certain cases where the lung cancer is very small. We have this technology called stereotactic body radiation therapy, or some countries call it stereotactic ablative stereotactic ablative body radiotherapy, SABR, where we use a very focused beam or set of beams of X-rays to target a very small tumor, and basically that gives a very good chance to ablate the tumor instead of using surgery.
Right.
So we have used that for patients who are unfit for surgery or patients who decline surgery, and that's a pretty good treatment option.
Right.
Okay.
So, Doctor, when you say ablate, what does that term mean?
Yeah, so for radiation, we know that radiation can harm tumor cells and kill tumor cells, and we have this concept called the dose response, where the higher dose we give, the higher chance we are to kill most or all of the cancer. The problem is that it can also damage normal cells next to the cancer, so we have to be really careful that we can apply a high dose to the tumor and kill or ablate that tumor, and yet spare neighboring normal cells. So that is the crux of our specialty.
Okay. So the good cells can get damaged as well at the
Yes,
same time.
good cells can get damaged. That's why patients do get side effects. These side effects can come on soon after radiation, so within weeks, and rarely they can come on even years later.
Right.
So this is something that we are also very mindful when we give treatment.
Right.
So our job really is to give the highest cure rate at the lowest risk of side effects.
Okay. Great. So how it has been so far when you use these machines?
Well, back when I started training and before I started training, so 20, 30 years ago, we weren't really using much computing technology. So we were using transparencies to plot the path of the radiation,
Right.
and using a few transparencies to sum up the radiation dose that we want to deliver to the tumor.
So Dr. When you say transparency, if you can explain it a bit, how?
Yeah, so back in the day, you may have used, or your teachers may have used this thing called OHP, overhead projectors.
I've never gone to a medical school, so.
Oh no,
Probably.
in primary school.
Yeah, in the local schools.
Yeah, local schools, okay.
So where you put a transparent piece of plastic and you can write things on it,
Oh,
and
okay.
then that can be projected onto a large screen.
Right.
Yeah, so this used to be the basis of our radiation planning.
Right.
So
That means if let's say, not me, if somebody has a tumor in somewhere here,
Yes.
so or sorry, in this area, so
Yes.
you point and
Yes.
you put something transparency and point and identify the area.
Yeah.
Is
So
it?
for example, if a patient had a brain tumor, we can take an outline with a soft lead ruler, if you know, of those flexible rulers,
Right.
an outline of your skull,
Wow.
and then based on that, we can plan. You know, if we give X-rays from this direction and that, how the radiation dose would be for the tumor.
Right.
This is in the days before, well, your computer, is
Wow.
on your
So that was
smartphone.
like, okay, sounds very, very detailed manual. Like,
Yes.
yeah. Okay.
So actually, the advances of the field have been generated by improvements in computing power. So
Right.
right now we use pretty fast processors,
Right.
GPUs to calculate. Yeah.
So when Dr. Ivan was sharing, I can imagine he's having the ruler and pointing and okay, this is the area. That came to my mind.
Yes, in a way, and then we also use like some kind of marker to designate which areas
Right.
we will shield, and
Is it a permanent marker?
Yes, it's
Okay.
like or some kind of lead crayon, a kind of crayon.
Okay.
Yeah,
Okay,
that we
got it.
just draw on the.
Right.
Yeah.
Okay. Cancer, what I've heard, I mean, both of you are here. It's not a death sentence at the moment. That's what I heard. So we want to talk about this so that it becomes very simple. The moment you say cancer, I mean, there is no answer. That's what we used to be. But things have changed, evolved.
Yes.
So that's why we wanted to make the conversation very lighter, so that audience also understands.
Yes.
So how it has evolved, doctor?
Yeah, so now we can compute the path of each proton. For example, if we are doing a proton plan, based on the energy and which direction they're coming from, the computer can tell us it will land how many centimeters away from this organ and that. So we can do that on the level of each proton, and there are millions, billions. So it's an enormous amount of computer power that we can now harness to generate the best possible treatment plan for each patient.
Right.
And of course, each plan is individualized. It depends on the location of the tumor, the
Customized,
nature
huh?
of the it's
Okay.
customized to the shape of the patient, the shape of the tumor, the kind of tumor biology we think that mass has. So it has really come a long way in the past 20, 30 years.
Got it. So we were talking in the morning about the normal radiation therapy machine and proton therapy. So before that, if you can just tell us the differences. What is the difference?
So the mainstay of our treatment is still treatment using X-rays. So X-rays travel at the speed of light. They come in from outside of you. It passes through your body. It comes out the other side.
Right. So that means if this is the surface, it will come here and then come out to the other side.
Yes.
Okay.
So if
that's
you
the normal
imagine-
radiation.
Yes. If
Okay.
you do if you go for a chest X-ray,
Right.
the X-rays are shot from the back. They come up through your front and they get captured. The image gets captured on a film, a digital or actual film.
Right.
So X-rays penetrate through the body very easily. Okay. So to harness this energy of X-rays to kill tumor, we shoot the X-rays from different directions. And so the focusing of that area would be where the highest dose of radiation would go. Also means that the surrounding areas do get a small amount of radiation.
Okay.
So that's what we normally do, and by using many directions of the X-ray beam, we can give a very high dose to the target and a very low dose to the surrounding tissues. But that is also the limitation of X-rays, because we can't stop the X-rays just going towards the target and stopping right there. So protons are heavier particles. We can determine where they stop in the body. So we shoot them from outside. They pass through your skin, enter into your body, and at the pre-designated depth, they will discharge the energy and stop there.
Right. Okay.
Yeah. So in terms of giving a targeted kind of punch to the tumor, the proton beams would be better compared to X-rays.
Right. So in this case also, does that, when you do the proton beam, does it come out the other side?
Yeah, it doesn't come out the other side, but as it enters the body through the skin, it will still deliver some radiation dose on the way in. So we have solved half the problem. Okay. So radiation doesn't come out behind, but it still gets deposited on its way in.
Right. Are you happy using proton therapy?
We're happy, yeah. It doesn't solve all the technical problems, but it's certainly a step in the right direction.
And definitely, compared to planning with the scale and everything, this is a different kind of planning and more precise, more solid. I would say. Okay.
Yeah.
I can see Dr. Ivan smiling. Okay, so he's happy. Okay. Coming back to Dr. Tanujaa. So there was a big word I just want to mention on genitourinary cancer you look at. So what does that mean? What is it all about?
So genitourinary cancers generally refers to cancers that occur in the genitourinary tract. And what exactly is the genitourinary tract? It's the organs that help you to pass urine, right? And so you have your kidneys, you have the ureters. These are, so the kidneys produce the urine, and then the ureters bring the urine from the kidney into the bladder, and the bladder is where the urine is stored. And once you're ready to pass out the urine comes out through the urethra.
Right.
So these are what we call the genitourinary organs, and cancer developing in any of these organs are considered genitourinary cancers.
Wow. Thank you so much. I feel like I listened to a teacher lecture. Okay, got it. Okay, great. So what has been, gens, right? PSA, I always come across this, okay, my PSA is increasing slowly or faster. In fact, my neighbor recently, he is going through some chemo at the moment. So he was saying that initially it was growing slowly, and then later on it became faster. So what is PSA?
Okay,
right?
So PSA stands for prostate-specific antigen. This is a protein that is produced by the prostate gland, right? And usually, what we have been doing is we've been measuring the PSA levels in blood tests, right? And we say that, and PSA can be, we have a normal range, so, and it depends on the lab that you do the blood test in. So if your PSA is raised, then we say that, hey, why is it raised? But it's important to know that the PSA can be raised for many reasons. It's not only raised in a situation where you have prostate cancer. So let's say, for example, if you have an infection of the prostate gland, or if you have inflammation of the prostate gland, the PSA can be raised.
Oh, okay.
So a raised PSA does not equate to cancer.
Wow, thank God. That's a big relief.
So,
okay.
And of course, it depends on the level to which the PSA is raised. So let's say if the normal is from 0 to 4, and if you come up with a PSA of 100, for example, then wow, that's really high, and then your suspicion of this being prostate cancer is definitely going to be higher.
Right.
But let's say if you do a test and your PSA is, let's say, 5, it's slightly above the upper limit of normal. So is it immediately cancer? No, it may not be. It may not be the case at all, right? And there are also cases where we see that patients have prostate cancer and the PSA PSA is normal.
Oh,
Right.
that also happens.
Yes.
Okay.
Right. So the way to diagnose PSA is more like a screening blood test, right?
Right.
To tell us whether there's a possibility of prostate cancer, but it is not diagnostic of prostate cancer. So, for example, if you do a blood test and your PSA is raised, we would say go and see a urologist first, and then speak to them, and then they will do further tests to assess you and see whether you need further imaging like an ultrasound scan or MRI, or if there's and from these scans, if they're really there's very high suspicion of this being prostate cancer, then they will advise you to go for a biopsy. Yeah, but there are situations where the PSA may be raised, and then we think that this may be an infection. You may have a course of antibiotics, and then you come back, and then the PSA is normal. So I think the message to the audience is generally a raised PSA does not always equate to cancer, and a normal PSA does not mean that you don't have cancer.
Wow, wonderful. Thank you so much for the clarity. I got a lot of clarity with that. Thank you. Another specialty you look after is geriatric oncology. What is geriatric oncology?
So basically, I'm a medical oncologist. So what I do as a medical oncologist is that we give systemic treatment. So like Dr. Ivan, he's a radiation oncologist. He gives radiation. So as a medical oncologist, I do systemic treatment. And what we have realized is that cancer tends to be a disease of the older patients, right? As we age, the chances of us getting cancer becomes higher, right? And why my specific interest in geriatric oncology? Because I think it's a subspecialty of increasing need, because from a lot of developing countries we see an aging population, so our cancer numbers in older patients will increase, and older patients have very different care needs compared to a younger patient, right? So and that's really basically geriatric oncology is focusing on how to optimize treatment for older cancer patients so that they can tolerate treatment in a much better fashion, right? So and how we can optimize them in terms not just from the cancer point of view, in terms of many other factors such as social support, emotional support, psychological support, and we also want to look at how we can help as well as the family members. It's more of a holistic care of the older patient, because the older patient, they may have cancer, but they may have many other comorbidities as well, right? They may have high blood pressure, diabetes, cholesterol, heart problems, and once you have cancer, you have these comorbidities as well. Treatment of the older cancer patient becomes more complex.
Right, and so it has to be on certain age, above age to be.
Generally, this age limit is very arbitrary. So, for example, we generally use a cutoff about 70.
70.
Yeah.
Okay. Got it. Okay. Great. So, coming back to Dr. Ivan. So, this urological cancer we are talking about, when it comes to radiotherapy, how does that work? How the treatment works?
Yeah, so we do see a fair number of patients with prostate cancer who do need treatment. Just to elaborate a little bit about the prostate cancer, the first thing we want to know, besides the PSA level, is whether the prostate cancer is high risk or low risk. For many patients with low risk or very low risk prostate cancer, especially if the gentleman is fairly advanced or more senior in age, it can be that he could die with the cancer and not because of the cancer.
Because of the cancer.
Yeah. So there are cases where prostate cancer does not need and should not be treated at all. On the other hand, there are prostate cancer patients who have high risk of fairly aggressive cancer, in which case they often will need a combination of therapies, and in many cases it could be radiation and drugs such as androgen deprivation therapy drugs, which bring down the male sex hormone. So with radiation, with or without these drugs, we do have a fair chance to treat and cure many of these patients with high-risk disease or at least intermediate risk prostate cancer.
If somebody has a prostate cancer, what would you recommend? A normal radiation therapy or a proton therapy? what would you recommend?
Yeah, so first off, actually, we go back to the question of age. We see whether the cancer will outlive the patient or not, in the sense that if the patient is 90 years old, bed bound, very frail, cancer is low risk, we don't treat, right? So in other situations, then I think it's important for the patient to have a balanced opinion with the urologist as well as a radiation oncologist, because in many cases, prostate cancer can be treated quite well with either surgery or non-surgical treatment such as radiotherapy. And the main difference actually is the kind of side effects that the patient may face after surgery or after radiation. If the patient chooses to have radiation, X-ray treatment or proton therapy can be prescribed. I would say the differences are not that great, in the sense that we are pretty good with the use of X-rays, multi-beam treatment. We do cure many patients with minimal side effects with X-rays. Protons do add a slight advantage. However, it is not readily accessible. It is more expensive, but it's certainly a discussion worth having with the patient.
Okay, great. Dr. Tanujaa, this geriatric, so is it older patient has more possibility of having cancer than a younger patient?
Yes, so statistically, yes, yeah, because as we age, chances, as we grow older, you have a higher risk of getting somatic mutations, risk of cancer increases, and generally certain types of cancers like prostate cancer is a cancer of older people. Yeah, but this is not to say that if I'm young, I cannot get cancers as well. Recently, there have been some studies that show that the cancer incidences in the young are increasing as well.
Okay. So, cancer screening, is there any specific timeline, or once a year, what would be the timing, what would be the age a person should do a cancer screening?
So generally the aim of cancer screening is to pick up cancers at an early stage. So by diagnosing cancers at an early stage, we hope that the chances of cure is higher, right? So, and cancer screening is usually very country based, and also depends on the prevalence of a certain type of cancer in your country. So for example, if I'll give you an example of Singapore, breast cancer is our number one most common cancer in women in Singapore. So we have a national screening program for breast cancer. So it is advised that for women above the age of 40, they should get a yearly mammogram. Yeah.
Okay.
And
age of 40 must get an
yearly,
mammogram.
we get a yearly mammogram. And the other cancer that we can screen for and pick up at an early stage is cervical cancer, right? So what we do is we suggest regular pap smears for anyone who is above the age of 25 and have been sexually active, is to go for pap smears usually once every 3 years. Nowadays, with our pap smears, we do a specific test called HPV testing. HPV stands for the human papilloma virus. It is found that about 70 to 80% of our cervical cancers are caused by the human papilloma virus. So we test, during the pap smear, we test for the human papilloma virus. If let's say you're negative for that, then you can do pap smears once every 5 years.
Right.
The other cancers that we talk about that we can potentially screen for is colon cancers. Is also one of the top most common cancer in males and females in most developed countries. So it is recommended that people above the age of 50 at least go for a colonoscopy. If you have no access to colonoscopy, a fecal occult blood test is another option.
Okay.
Right? And another possible cancer that we can screen for is lung cancer. It's been found that for patients who are high risk of lung cancer, you generally deemed to be people between the age of 55 to 74 years old who are heavy smokers. It's recommended they go for a yearly low dose CT scan of the lungs to pick out early stage of lung cancers.
Okay. And this term called genetic testing, what is it about?
Okay, So again, great question. Genetic testing, as I mentioned previously, so there are certain cancers that have a higher risk of having inherited genetic mutations. So certain common cancers are like breast cancers.
Can I stop you, doctor?
Yes.
Genetic mutation, what does that mean? If you focus on that word.
Okay, so basically your genes are part of your DNA, right? Sometimes sometimes what happens is that there may be abnormalities in the DNA, right? And these abnormalities you may be born with these abnormalities. And so if you have inherited an abnormality in a particular gene, like for example, I go back to the BRCA mutation, it's called the BRCA mutation. If you have inherited it, the chance of you getting breast cancer or ovarian cancer in a female at an early age is very high. So we are talking about maybe 60 to 70% chance of getting breast cancer early, right? So for example, when would I offer genetic testing for a patient? So for example, if someone comes to me with if a lady comes to me with a breast cancer and she's young, right, and let's say below the age of 50, and she has a very strong family history of breast cancer, then I said, let's go for this genetic testing to see whether you have this mutation. Because if you have this mutation, then the type of surgery that you go for will be different, and also the type of medications that we can potentially give you would be different, right? And we also can do genetic testing for patients, for people who do not have cancer. So for example, if I've seen patients, not patients, individuals who have a very strong family history of cancer. So someone who come to tell me that, hey, they have a mother who had breast cancer, 2 or 3 aunties with breast cancer, and this is a young person. For them, they would do genetic testing to see whether if they have inherited this mutation, and if they have inherited this mutation, then what we can potentially do is talk about risk reduction surgery. So sometimes they even, if you want to go the whole 9 yards, people talk about going for bilateral mastectomies or even going for surgeries to remove the uterus and ovaries. But of course, this may not be something feasible for everyone, especially if you are young. But if you know that you have this mutation, then your screening that you do would be very different. So if I have this mutation and I'm young, a mammogram would not be appropriate for me. I would need to go for an MRI breast screening. Right, so that's how genetic screening works. Yeah, genetic testing is not for everybody, so you need to, and there are of course implications about doing genetic testing, and that's a whole conversation on its own. But essentially, if you have a very strong family history of a particular type of cancer, or if you're a young person diagnosed with cancer, then these are certain groups of people where we want to consider genetic testing for.
Got it. Yeah. So, being representing Parkway hospitals for the last 20 years, I get a lot of inquiries. Say that genetic testing, how it can help. So this conversation would definitely help. So and that's the main objective of doing this, to bring in the specialists so that they can talk about it. So we will be bringing in a local specialist also to share in the same platform. We'll go on to the next segment of anything else you want to add?
Not at
Anything I missed out?
No, I think I maybe go back to the point that you made earlier, that cancer care has evolved greatly, and cancer is no longer seen as a terminal disease.
Right.
Right. So
Yes.
cancer care has not only advanced in terms of treatment and the therapeutic options that we have, also in terms of diagnostics. So in the past, whenever people thought of cancer, the only thing they think about is chemotherapy, and everybody fears chemotherapy. But nowadays, we have so many other treatment options. We have targeted therapy, we have immunotherapy, we have antibody drug conjugates. And when we come to talk about diagnostics itself, whenever we talk about, let's say, a cancer, last time whenever we talk about lung cancer, everybody with lung cancer got treated in the same manner, right? But nowadays, whenever we talk about lung cancer, it is not one disease, right? We are able to now go down to the molecular level, identify the specific genetic mutation that is driving the cancer, and we've got drugs to target that. So
So that's targeted therapy.
Exactly.
Okay.
Right? So, an immunotherapy, in short, is basically therapy that activates your own immune system to fight the cancer cells.
So activate their own immune system. Wow, that's
Yeah.
amazing.
So I think most people think cancer equals to chemotherapy and equals to equals to death, right?
Yeah, if you ask, exactly, that's what I think. Yeah.
Yeah, but I think it's important to know that that is not the case anymore. There are many people, even with stage 4 cancers, that live for very long, and we now look at metastatic or stage 4 cancers more as a chronic disease rather than a terminal disease. Yeah.
So how this targeted therapy and immunotherapy has changed the treatment realm of it? Did it have a huge impact?
Of course. In fact, with the advent of immunotherapy, there are some cancers that were said to be, metastatic, stage 4, that we have potentially even cured the cancers.
Right.
Yeah. So it's really changed the treatment landscape of cancer care greatly.
Wow. This is your second visit to Sri Lanka and Dr. Ivan, first time, and so you have worked with some local oncologists as well. What do you think about them?
They're brilliant. They're fantastic. So it's been great to have been able to, for the local oncologists that I have collaborated with and worked together with for some of the patients. It's been very good, because some of them, the patients come to Singapore for treatment, but obviously the patients can't stay in Singapore for a prolonged period of time. Some of them go back to Sri Lanka to continue their treatment or for follow-up, and generally working with the local oncologists has been very useful for me, because and they've been very receptive. It's easy to talk to them, to communicate, like, treatment plans, can you help me to do this, and they've been absolutely amazing.
Yeah, I mean, that's my experience also. Last 20 years I've been working with the oncologists. One thing comes to my mind when I think of Sri Lankan oncologists, the sense of giving. My God, they love to give. I had the privilege to work with them for 20 years. And then I've seen how they have managed patient, even my own family members, they have taken care. It's absolutely amazing. Great.
I agree.
Yeah. So Dr. Ivan yet to find out, because first visit. So
he will find out.
But then again, he has actually co-managed some of the patient also, which you have.
Yeah, we've had many mutual patients.
Yeah,
together.
mutual patient. He has done that. So this is second segment. We are going to see what is fact and what is myth when it comes to oncological care, right? So, Dr. Tanujaa, are you ready?
Yes.
Okay. Only smokers get lung cancer. Fact or myth?
Myth. We spoke about that earlier, right?
Right. Yes. Okay. Head and neck cancer only affects older men.
Myth again. Head and neck cancer can affect people of any age, and risk factors for head and neck cancers includes tobacco smoking, chewing of betel nut leaves, and human papilloma virus.
Thank you. Drinking alcohol does not increase the risk of head and neck cancer.
I would say excessive drinking would increase the risk of head and neck cancers.
Okay,
Yes.
got it. Okay. The word is excessive, is it?
Yes.
Okay, ladies and gentlemen, you know the word, which is excessive. Okay. Urological cancer, like prostate or bladder cancer, always show early symptoms.
Again, myth, right? Sometimes patients may not even know that they have this cancer, and this may be an incidental finding either during a scan they go for, or they may do a blood test, for example, the PSA, and they find that it may be raised, and then found to have prostate cancer. They may not have any symptoms.
Okay. Only men get urological cancer.
No, that's not true. Because ladies have kidneys, ureters, and bladders as well. So females can still get urological malignancies.
Got it. Okay, thank you. Okay, geriatric cancer is untreatable due to age.
No, complete myth. So
I love the confidence.
Yes. I'm a geriatric oncologist, right? So No, we can treat any patient despite their age, but basically they need to be assessed and we need to optimize their function before treatment.
Great. Lung cancer is always fatal.
Myth. Lung cancer, if picked out in an early stage, is potentially curable.
Potentially curable. Wow,
Yes.
that's brilliant. Okay. HPV is only linked to cervical cancer, not head and neck cancers.
Myth. So as mentioned earlier, HPV increases the risk of certain head and neck cancers, especially the oropharyngeal cancers.
So, blood in urine is always due to an infection, not bladder cancer.
Myth. Blood in the urine can be due to many reasons. Essentially, what it just means is that you need to be evaluated by a doctor.
Okay, great. All older adults will develop cancer at some point.
No, myth. Hopefully not.
I think that I also can answer. Okay, great. Thank you very much, Dr. Tanujaa, for your contribution.
Most welcome.
Now we move on to Dr. Ivan. So, Dr. Ivan, so your the latest machine you're working with is proton therapy.
Yes.
So we want our audience to know that what is it all about. So most of all my questions will be in that area, and because we must support our patient with the cutting edge technology, and you are the man who's doing that with that whole proton therapy machine, right? I've seen it. It's amazing. I shouldn't say amazing, but it's a machine. But one thing I liked about it in our center, I think it was in the basement, 5-story down, right?
Yes.
And it took 5 years to
Yes.
put it up, right, doctor?
Yes.
Yeah. So, so first question. Proton therapy is experimental and not widely used.
Oh, myth. It has been in use for many years in many countries, and that is a standard for, it can be considered a standard for treatment.
Great. Proton therapy is only for rare cancers.
Oh, myth. So proton therapy can be used for common cancers as well as rare cancers. Common cancers we are treating include some kind of brain tumors, head and neck cancers, prostate cancers, and others.
Okay, great. Proton therapy is more dangerous than traditional radiation therapy.
This is an interesting question. So for our field, really, we want to see where the tumor is and which is the best way to tackle that. So for example, skin tumors, we don't need and we shouldn't be using proton therapy. Simpler techniques will work better. So proton therapy is not the answer to everything, unfortunately.
Okay. So next one is proton therapy is painful.
Oh no, it's not painful. Radiation in general is not painful. You can have painful side effects down the road, which it will be on a case-by-case basis, but actual treatment and delivery is painless. You don't feel a thing. You don't feel hot. You don't feel burning. And there's no radiation in you once you leave the room.
Doctor, I will look very happy with that question. Okay. So, proton therapy is only for children.
Myth. I would say the benefits of proton therapy in children would be very significant because children are still growing, so we don't want to interfere in the growth and development of the children. And so proton therapy does have a significant edge over regular X-ray treatment.
Proton therapy completely eliminates cancer without the need for treatments.
Oh, that's a myth as well. So we work closely with medical oncologists and surgeons. Again, many cancers may need multidisciplinary care, so we all work together as a team.
Proton therapy has several long-term side effects.
That is a fact. We can cause side effects with any radiation, including proton therapy, but I must say the risk of late side effects would generally be lower with proton therapy.
Great. So next, is it a myth or fact? Proton therapy is unaffordable and not covered by insurance.
Well, it really depends on your insurer. So in Singapore, most of the local insurers will have some provision to cover proton therapy. In Singapore, the proton therapy delivery is regulated by the Ministry of Health. So there's a committee that oversees the use of the proton therapy nationally, not just in our center at Mount Elizabeth Novena. So that will dictate what kind of patients can be treated, and the specifications and standards for each center.
Okay, great. Proton therapy is the best option for all types of cancer.
That's a myth. Yeah, we covered that earlier. It really depends on the type and location of the tumor.
Great. Proton therapy is available everywhere.
Well, that's also a myth. I would say, proton therapy is available in some countries. We also, as a radiation oncologist, I also would like to see more regular X-ray facilities available to patients in Asia.
So this segment is, I ask all the specialists who come here and share their knowledge. So there's 3 questions I'll ask you as well, and after that, Dr. Ivan. One lifestyle-related tips you will give, and why?
Exercise. So it's important for everybody to engage in some form of exercise. It's recommended that we aim to get 30 to 45 minutes of moderate intensity exercise every day if it's possible, and that has shown to decrease the risk of cancer. Second thing that we should all do is eating a healthy, well-balanced diet, and what exactly that means is really to eat more fruits, more vegetables, whole grains, and avoid processed food. I think these seem like very simple advice, but generally not very easy to follow.
Got it. So second question is, when I say the line, I want to live a healthy life, what comes to your mind?
I think the same things, right? So if you want to lead a healthy life, at least for myself,
No, it has to be different than that. Something different than that. That's the tips you gave, right? So when I say the word,
I want to
it's
lead.
like, Shubha, I'm going to kill you. Okay, got it. Okay.
Okay, I want to lead a healthy life.
The moment I say, I want to live a healthy life, what comes to your mind? And you gave us 2 tips actually, not 1 tip.
No,
Earlier.
no cancer.
Okay, sorry. Say it again. Say it again.
No cancer.
Okay, so when I say the line, I want to live a healthy life, what comes to your mind?
No cancer.
Okay, great. Okay. Last question. In life, when we do something, it's 20% skill and 80% psychology. When I say that, what comes to your mind?
May not always be the case. I think in our specialty, I think skill is also very important.
Right, got it. So would you say 50-50 or?
I suppose it'll be 100-100.
Okay, great. Thank you very much. So, Dr. Ivan, over to you. So, one lifestyle-related tips you will give, and why?
So for our listeners out there, if you are smoking, I would strongly encourage you to consider quitting. It's not easy, but there are many ways available to help you kick the habit. It's not just about cancer risk. Smoking will also increase the risk of heart disease and strokes. So I think quitting smoking would be the single lifestyle thing that you can do to improve your overall health and longevity.
Great, thank you. So when I say I want to live a healthy life, what comes to your mind?
I would say having a positive mindset, being optimistic. We know for some reason optimistic patients actually live longer than patients who are pessimistic or depressed. So I think there is certainly a mind-body connection, whether in cancer or other illnesses.
Followed by, is life 20% skill, 80% psychology? Do you believe in that?
I think it depends, yeah. So for some endeavors, I would fully agree with you. In kind of professional fields, maybe I would want my surgeon to be more skillful than 20%. Yeah.
I love the honesty. Great. Okay. Great. Thank you very much, Doctor. Thank you so much. I'm so excited. You have been a wonderful, wonderful contributor to this program, and I'm excited that finally we are doing this, right? And a bit of I was just thinking of Dr. Tanujaa because last year when she came. So, ladies and gentlemen, don't be mistaken. She's from Singapore, but her name, Tanujaa Rajasekaran. So when last year she was here, Dr. Ivan. So what happened is, we took her to Maharagama Apeksha Hospital, our National Cancer Center. So the doctor specialists over there, they got to know her, and then they were saying, "Oh no, you're one of us. Your name and everything it's so Sri Lankan." So thank you, Dr. Tanujaa, for coming back. Your contribution. Really looking forward to help a lot of people through this podcast and with your contribution, Dr. Ivan. Even though it's your first visit, I know you for the last 2 years, and I know how you have helped our patient, and we are very extremely grateful that you are here. And I sound very formal right now.
Happy to be here.
Great, thank you.
Yeah, thank you so much for having us, Shuvo. It's our pleasure.
Great, thank you. So with that, ladies and gentlemen, so knowledge is not power, knowledge is potential power. Now you know, and we have shared, our specialists have shared that simplified version of how you can manage yourself, how you can screen, go for screening and find out earlier so that you don't have to be suffering with this dreaded disease called cancer. Because cancer do have answer at the moment. It has become a chronic disease. That's what we have learned from the first episode of Health Matters. Thank you very much.
Thank
you.
you.